massage, yoga when they're available, those types of things, when we reviewed all of the evidence and found that these were effective modalities for these types of conditions. As part of this, we wanted to limit the types of treatments that might be not as effective, and these included mostly long-term opioids. Go ahead, Jason. So that was the proposal that we forwarded to the Value-Based Benefits Subcommittee and the HERC. They met in August. We received a lot of public testimony, many written pieces of testimony from patients and from providers, and we heard quite a voluminous amount of public testimony at our August meeting. And there's been various articles, etc. So there's been a lot of interest in this proposal, as well as a lot of feedback to us. So obviously I can't show you all 400 written documents that we received, but basically, they're all made, yeah, they've all been available to you on the website. But staff has kind of done a qualitative, subjective sort of summary of the main things. So there was some concern among patients and providers that the services that we were offering may not work for some patients, or they're not sufficient. They might be helpful but not completely sufficient. They mentioned many different types of conditions, and we realized that we really needed to clarify what conditions we're talking about. We've actually gotten feedback from the Oncology Society, very concerned that we were going to take patients who have active cancer and not provide appropriate pain therapy, etc. So we've been hearing some information, so that was one point that staff took, is this group needs to really clarify that we're addressing just specific diagnoses. Go ahead, Jason. And then there was most of the feedback really centered around the control on opioids that we had been proposing. So just to remind you, what we had wanted to propose was limits on short-term opioids that were went along the lines of what we've put in place for the last couple of years for back and neck pain, which would have very limited prescriptions for 90 days and then no long-term therapy, and patients who are on long-term therapy should be tapered off. We heard a lot of concern from that, and you can see basically saying that patients felt that if they were tapered off, it would really affect their pain and function. It may lead to increased rates of suicide or increased rates of heroin use or other adverse events. And that they felt that these types of decisions should be made between a doctor and a patient and not by expert panels or government or things like that. So based on all of this feedback, as well as you also have in your packet the VBBS minutes, so that there wasn't a lot of feedback at that meeting because most of it was sort of in listening mode, but and subsequently we've gotten feedback from the CCOs and other groups, just kind of at all of our stakeholders. And there's a few things that we definitely need to address with our proposal. First among them, actually these are a few things that just came up. These are just sort of details. We were asked about central pain syndrome, which is kind of a little bit of a different animal. This is actual damage to the brain from a stroke resulting in pain. And whether it's currently on a funded line, so there was a question about whether this should be included in this particular proposal. The clarification of the population we're talking about. Our proposal actually only had 5 diagnoses, which were chronic pain syndrome, chronic pain after procedure, chronic pain after trauma, other chronic pain, and fibromyalgia. Those were the only conditions that we had actually included in our proposal, but how to make that clear in the guideline or in any other types of things that we're not including arthritis or active cancer or those types of things. And then there was a lot, not a lot, but we did get some pushback. Some of the CCOs is particularly pushed back on fibromyalgia, that they were concerned about coverage for fibromyalgia, that this would they felt that it should not be included in that line. So what we have asked, and one of their major concerns was the medications for fibromyalgia, such as Lyrica and Cymbalta and those types of things. So as part of that pushback, we've asked the Pharmacy and Therapeutics Committee to do a review of the medication classes to treat fibromyalgia. They haven't done this previously because it was an unfunded condition. So they are going to do that at their November meeting, I believe. So they are currently conducting that type of review, so we'll have some more input and some more information, hopefully before our next meeting. And then the strong voice that we heard from the public about the opioid issues with this, so we felt that we should do a little bit more in-depth look at the effectiveness of opioids for long-term pain, the harms, the effectiveness of tapers, etc. There are multiple reviews, etc., which have been done looking at long-term. So the studies on opioids for long-term pain have never really been done long-term. They're usually in short-term studies, so we don't have a lot of data on the effects after 3 to 6 months. There have been some, like the Chow review, that showed that the evidence for long-term treatment was pretty poor. There was recently a trial called the SPACE trial that was published. I'm sure you've probably heard about it in the press. It's where they randomized, it was an RCT where they had opioids, ibuprofen, and Tylenol, and they followed patients for a year, and they actually found that ibuprofen was the most effective pain control medication, and opioids and Tylenol were less effective in long-term control. So we need to go through this, and I'm not going to take up a ton of time and go through all these reviews, but they're in your packet just for your information, and we can talk about those in more detail. And then the CDC prescribing guidelines, I'm sure you've heard of. There was a very strong thread that we heard in public feedback about the concern that if we taper folks from opioids, that we are going to increase heroin use. So staff specifically looked at that. I need to clarify some of this data. So this is based on NIDA, and NIDA has, in all of their studies, when they've looked at opioid users, people who are currently using opioid, about 80% report that 80% who have started in the last 10 to 20 years report that we will have public testimony that.
Clarification question. There are a lot of people who don't understand acronyms, so we're.
I was just going to say that.
Would you mind?
Okay.
Thank you. Appreciate
The
it.
National Institute of Drug Abuse. So it's one of the NIHs.
And CDC is Center for Disease Control.
And yeah.
Thank you.
So the National Institute of Drug Abuse has done extensive looks at things like heroin. They have a report where they talk about back in the 60s and 70s when they looked at at heroin users, the vast majority had started with nothing, so kind of de novo, or they had started with marijuana, alcohol, actually cocaine I think was the #1 kind of starter drug. In the last 20 years, when they asked current heroin users what started them, 80% say pharmaceutical opioids. The vast majority of those are probably diverted, so
Yes.
The vast majority of patients, it wasn't a patient who was getting a legitimate prescription that went forward, but it was the opioids that were in circulation that these patients were using.
That they were stolen from patients or family.
So, could the audience
Correct.
please refrain from speaking
sorry, I was
until public
asking.
comment?
So the majority had prescriptions that were not their own or were not legitimate, but there were some that legitimately received their own prescriptions and then went on to use heroin. And then when you look at there are 4% of prescription opioid users, and that actually, I need to clarify that. That's 4% of people who are on chronic prescriptions who are already identified as misusing them, so a much smaller population, go on to use heroin. So we're looking at, when you look at legitimate opioid users, or people who have legitimate prescriptions, a very, very, very small percent in any 5-year span will go on to use something like heroin. And that would, they did not look specifically to see if those patients were being tapered or otherwise changed, but presumably in that population there would be some that were being tapered off or otherwise. And there would be some who would be tapered off who would not be going on to using heroin. So it's that piece of information, that specific question, what happens when you taper someone off opioids, what percent go on to use heroin, there is no data on that. However, if you go on to the next slide, so there have been, this is a a new field that's just been, there's just been papers published in the last few years on what happens when you taper folks off opioids. And again, this is a new field, but the papers that are coming out are all uniformly positive, that patients, when they're tapered from long-term opioids, either have no change in pain and function or it actually improves. So we are going to go ahead now. We have two folks who are here to give us some input. The first is Dr. Tom Jean. He's from the Oregon Public Health Department. And he's going to give us an overview on the data that is available right now publicly at the public health website on opioid issues in the state, as well as updating us on what is going on. So welcome, Dr. Jean. Thank you. So you can, if you have slides, you're welcome to sit here or